very pleasant good morning. It is time for Bone Talk from Florida Orthopedic Specialists, live from Stuart, Florida. Wow, this is amazing.
Hey, good morning, everyone. Yeah, we're doing this one on audio and video today. I'm Dr. Joe Wierzbicki, and I'm here with Dr. Johnson, Dr. Paul Johnson.
Oh.
Yeah. So our first of many video, audio bone talks. So this one should be available not only live audio, hearing it on the radio, but also video recorded and can be accessed on FloridaOrthopedicSpecialists.com and at WPSL radio. So it'll be available on social media platforms too, and you can see us or just listen to us live either way. Again, our number for Florida Orthopedic Specialists is 772-335-4770. And you can find us in Port St. Lucie off of Highway 1 and Walton Road, or in Stuart off of Highway 1 and Indian Street, closer to the intersection of Indian Street and Willoughby. So, Dr. Johnson, should we talk about some...
Hey, I like your elaborate television set there, huh?
You like our setup in the background here?
Yeah, it looks awesome.
Beautiful Florida in the background.
It's high class.
Well, I guess Dr. Johnson and I were figuring, let's do a real just committed hour of some arthritis talk, just start to finish. Let's start with how we typically approach things, with things that are low risk, high reward, and kind of moving up that hierarchy, that ladder, all the way to the top, which is a little bit more risky things like narcotics or surgery can be a little bit more risky compared to something like a brace. So
I think that's key, and you're right. You start off with simpler things because you can still get maybe a very good level of satisfaction, of function, of pain control with minimal risk or minimal downtime. And those things are very key when you're trying to get someone back up to speed as quickly as we can. And there's occasions where those things aren't working, so we kind of advance up that ladder. It's very stepwise, and I think a good approach to attack those things.
And sometimes patients say, like, so you can't fix arthritis, and it's so discouraging because they come in with this severe pain and they think, so I'm stuck with this. And we have some ways of looking at that in a different way. Yes, the arthritis is there, but we can improve a lot of your acute symptoms and make this a lot more livable. But yeah, there's no fixing the arthritis.
That's a great point. But I think what I tell folks when they're trying to get a handle on that is that the X-ray that's showing, let's say, that knee arthritis really didn't look any different the day before your pain started as it does the day that we're looking at it, maybe in the office, or the day after your pain started. So the architecture is unchanged. But if you were asymptomatic or minimally symptomatic, pretty comfortable, pretty functional before, there's a good chance we can get you back to that same level, even if, as you say, we can't fix the arthritis, make it go away. So I think that's a very important factor for folks to know. It's not hopeless. And a lot of times that X-ray looks a little daunting at times, or the word arthritis, they know mom and dad and grandma and grandpa started marching down that road. Get a little nervous, but I think there's a lot of approaches now that we have to kind of get someone back up to speed and actually pretty comfortable, pretty functional without having necessarily to end up at that surgical fix.
And actually sometimes even better than when they're coming in with that flare, because sometimes they're coming in with this chronic nagging pain, not getting any treatment with it until it's really flared up. And then of course we're getting them out of that exacerbation, but then sometimes even improving on that previous situation. With things like physical therapy or a brace or whatever else, just some education behind it.
Yeah, absolutely. And I think that is a great point. A lot of times those changes are so slow and progressive, and they kind of creep up on you. So by the time they hit that tipping point, there's already been a lot of weakening or stiffness, or as you say, that kind of chronic nagging quality about it that they've been able to push off and ignore. And then they just get to that point where they can't do it anymore. So you're absolutely right. I think we can kind of reverse a lot of that and get someone much more functional by addressing some of those quiet sort of secondary effects of the arthritis that they may not even realize they're dealing with.
Yeah. And just for some simple definitions, how do people define arthritis? I'd say that arthritis is pain from worn out shock absorbers in a joint, or pain from worn out or just inflamed shock absorbers in the joint. So sometimes you have some good cushion, but it's inflamed, and we call that an arthritis exacerbation. So oftentimes symptoms of arthritis, I hear a lot, pain after someone's been resting a while and then they first get up and get going, but it kind of warms up a little bit. And then oftentimes pain when you do too much. So kind of pain at the extremes is what I typically hear for arthritis, and it's wear and tear.
That's it, and I think you're absolutely right. That sort of startup pains are definitely a good clue, and that is a function of that inflammation, and being able to control those aspects of things is very key. So I think when someone comes in with those descriptions, those are pretty accurate in terms of very likely to be arthritis. You can certainly have swelling. You can have some tenderness around the joint itself, even some stiffness or a sense of fullness that does go hand in hand a lot of times with that swelling, where you've got extra fluid in a confined space. It's kind of like trying to bend an overinflated balloon in half. It's a little harder to do than when you've got some play in there. So less fluid, more mobile, more fluid, a little bit stiffer, a little bit harder to move. And I think that's it. Those are kind of the key symptoms for me that sort of say this is kind of where we want to start looking.
Yeah, yep. And so oftentimes we're starting with those low risk, high reward things, things that minimal to no risk. I mean, there's not much risk with putting a brace on or putting some ice or heat on it. Doing some proper exercising and stretching, using a cane or a walker. It always starts with these things. What do they call it? The price treatment or the rice treatment. Protect it, rest it, ice, compression, elevation, things like this. They work very well. And I think a big thing is just modifying your activities. So relative rest, not doing the things that give you pain. I mean, it sounds silly, but we got to say it every single day.
Absolutely. I always kind of preface that by saying it's some of the most obvious overpriced advice I can give you, but it's true. And I think sometimes people need to hear that. It really is one of those things where you need that latitude that you have pain. It's okay to slow down a little bit. Give yourself a little bit of time. Let let's say the knee or the hip calm down a bit. If you're constantly poking the bear, he's never going to go back to sleep. So you got to let it kind of give it its space to do that.
Yep. And so physical therapy is part of that group. And I'd say that next step up is probably talking about things like steroid injections or by mouth medications, Tylenol, anti-inflammatories. And it depends on really a person's past medical history. Are they on blood thinners? Do you have bad kidneys? Do you have a bad heart? And certain medicines may not be right for you. Steroid injections, there's not many contraindications, outside of diabetes issues or a rash at the site, but I think there's a lot of bad information out there on the internet about steroid injections. I tend to find that some of those worries or some of those clickbait articles are really magnified fears from really high strength, long-term steroids. Like when someone's on them for, lupus or rheumatoid arthritis, when you're on the high strength doses like that, it can irritate the bone, the joint, the tendons, the ligament, but that's not the same with a steroid injection. It's never been proven that a steroid injection causes damage to a joint.
And that's key. I think I hear that question more often than just about any other one. In fact, maybe is it going to hurt? Well, it's a needle. It's a little bit, not bad. But then the next question always, and what is this going to do to the joint? Is this going to wear it out? Is this going to do damage? What are how many of these can I get? And I think you're right. There's very few exceptions. And even in those, I think there's a fair amount of latitude. And as long as people are aware of what they're getting into with those specifics, that's fine. But for the average person, it can be a very powerful way to reduce that inflammation, which is in large part what people are feeling. We think it's a worn out joint. I'm feeling it grinding and so forth. You get some of those mechanical symptoms, but what you're feeling in terms of the pain, what's causing the swelling, what's adding to that pain is the inflammation. So getting that under control is the target for all of these treatments. And steroids are a great way to kind of do that in a relatively quick fashion. And as you say, with minimal increase in risk above that first line of treatment, those bracing, icing, et cetera.
I've got a question on the Tylenol aspect. If you are on a blood thinner, do you have to watch the amount of Tylenol that you would take?
So generally not with the Tylenol. Tylenol is going to be processed more through the liver and does not directly interact with any blood thinners or any of those issues. Anti-inflammatories, the non-steroidal ones, the other end of that over-the-counter pain relief section, that ibuprofen, naproxen, so Advil, Aleve, they can potentially. And so in some cases, folks have been either cautioned not to use those, or if they have a history of bleeds, sometimes GI issues or esophageal bleeding or ulcers, that's a bit of a different story. And so in those cases, I don't know about yourself, Joe, I usually
agree.
Start to stay away from them. If it's been a while, maybe they're not sure, I would still err on the side of caution, go back to those physicians that have helped them monitor their blood thinners or those, let's say, GI issues in the past, and get those physicians to make sure that they're okay with those pre-existing medical concerns.
Yep. The biggest absolute contraindications to using a lot of anti-inflammatories, and when we say anti-inflammatories, we're talking about ibuprofen, Aleve, Motrin, Advil, like I said, Motrin, and naproxen, naproxen, Mobic. The biggest contraindications are going to be being on a blood thinner, having kidney disease, and a history of GI bleeds. And so outside of those, everything else is it's a little bit more relative, kind of used cautiously. And Tylenol is separate. Yeah, good question. Yeah. So yeah, using those. Steroid injections. Another big thing with steroid injections is going to someone who does a lot of them. So we do dozens of these every single day. Practice makes perfect. We did a lot of our training doing this. And something that we believe in here that not all other orthopedic groups do is using image guidance and using technology. So I carry with me a handheld ultrasound. And so right in the room, I can use that ultrasound to watch the needle go to the exact right spot. We also have a bigger ultrasound that can be wheeled from room to room that's a little bit more high def than my handheld one. And that makes the injection 100% accurate. It makes it extremely unlikely that we're going to run into a tendon, a ligament, a joint, a bone that we're not supposed to. And I mean, it's already a sharp needle. It hurts a little bit when you pierce the skin, but if you run into a bone or a tendon, it's going to hurt a lot more. So that's why we believe in the ultrasound guidance or X-ray guidance for other injections in other parts of the body, like the back, for example.
Yeah, I think that's key. And a lot of studies have shown too that people think they're putting the medication in the right spot and they're not. And so without that ultrasound confirmation, you don't know for sure whether that injection did or didn't work because it was in the right spot. Maybe it was in the wrong location. And so maybe it would have worked if it had been appropriately administered. And there's just no substitute for being able to watch that directly. I think that's so important.
Yep. And the study I learned back in residency was a study that, and there may be new studies now, but they looked at injections in the knee with experienced orthopedic surgeons. They were 70% accurate at getting the needle to where it needed to be in the knee. 70%, and that's what we would say is our most confidently injected joint without any kind of image guidance. 70%. I like 100%.
Yeah, I'm with you. There's just no, and it's a full third of patients, and it's a little challenging sometimes when someone comes in having maybe seen some other physicians, and there's I know I tried that, and without knowing for sure that injection was in the right spot, you don't really know. So maybe you're jumping onto that next level of treatment unnecessarily when you could have gotten as much or more relief with something as straightforward as a steroid injection.
Yep. And you hear some people, they have bad knee arthritis, maybe they're bone on bone, and they get one steroid shot in their knee a year and they're great. They have no problems with it at all.
Absolutely.
And other people, they get one every 3 months. So there's still a lot we don't understand about why some people respond so well to steroid shots and other people not as much. But if you're one of those people and it works that long, well, fantastic. We want to utilize that low risk, high reward intervention.
And I think that's a great point. At the end of the day, it comes down to maintaining your joint for as long as we possibly can. At the end of the day, there is no substitute for that. As much as I'm a fan of things like knee replacements, hip replacements, they are very good procedures. But at the end of the day, your knee is still better as long as it's functional, as long as you're able to maintain that pain control. And so if we can sort of move that ball down the field a little further before we have to call it and start moving towards those bigger surgeries, I think almost universally people are better off for that.
Yeah. So I guess our next level up from steroid injections, as I start thinking about it off the top of my head, what would be next level up? Narcotics, or we say narcotics, muscle relaxers, maybe other nerve silencing medications. So other pain medications, I guess I would say is the next level
so,
up.
Yeah, those that have a little bit more risk to their use, that have a little bit stronger side effect potential. I think that's probably that class of medications you're describing. I think for certain joints that I would almost maybe include, or maybe this is just maybe a half step beyond that, some of those targeted like nerve therapies, the nerve blocks and those types of things can be helpful. Sure. But again, getting a little bit more invasive, that risk quality is going up a little bit. Again, still very safe overall, but if we're looking at that comparison basis, if you're talking about the difference between taking a Tylenol over the counter versus an injection of any kind, yeah, it's a little more risky, but at the same token, if we can get away with that lower risk, I think that's always the key. So I think that's kind of that level I tend to think of as moving on to.
Yep. And also kind of along that level is thinking about things that maybe aren't traditionally as successful as something like a steroid shot, but still is very successful. Something like a stem cell injection. Medicare just recently started to say yes to those. And so we're seeing some early promising studies, which is why Medicare is saying yes to them. Not as reliably great as something like a steroid shot, but still this is an option for people. And the one that Medicare is approving of now is an umbilical stem cell injection, or amniotic, excuse me, not umbilical, amniotic stem cell injection. So I always explain to people where that's coming from. It's from healthy newborn babies, totally healthy. The hospital's testing their blood and testing those fetuses and watching them. And these are healthy babies who are going to grow up. There's no other kind of political issue here.
Absolutely right. Yes, this is not.
Yep. So that extra tissue, like the placenta, the cord, that would normally just go in medical waste, is instead harvested. There's a lot of healthy cells and anti-inflammatory stem cells in there, and so it's sent to the pharmaceutical company. The pharmaceutical company purifies that and kind of concentrates it into a little syringe, and they send it to us, and for the right candidate, we inject it into whatever joint. So I think that's a lot of people's questions about it. Is it risky? Oh, and they're also, of course, testing that tissue themselves at the pharmaceutical company, you know, to make sure that there's no viruses in it or bacteria or any other kind of problem tissue. So multiple layers of checks there. And overall, my view of the studies is that it's fairly equal to something like the gel shot.
Yeah.
And the gel shot, the study that I like, it's that it's about 70% successful for people who are bone-on-bone arthritis. Everyone has their favorite study on that. That's the one that I tend to quote. And so when they compare it to that, 70% success, yeah, I'd like a little bit better than 70% success.
Yeah, but as you're, like you say, if it's your second line measure and we've gone through all those other steps at that point, yeah, I still think 70%, it's obviously better than a coin flip. It's a lot better than a coin flip. It's really a good chance, 2 and 3, a little more than that, to give you some good relief, even at those advanced stages of arthritis. So that's a pretty powerful weapon to have in the arsenal. And certainly, again, looking at that risk tier, much lower risk than the things like the surgical fixes for those issues. So it's worth, I think, in a lot of cases, at least a good look at and see if it's appropriate.
Yeah, and of course that gel injection that we're always talking about, we've been using that for 20 plus years in orthopedics. I'm not sure how long, and they continue to purify that formula and advance it and get it better and better. At first we were doing 5 injections, 1 injection a week, but now it's just 1 single injection in kind of this high octane form. And so we continue to use those gel shots. They work. Sometimes they don't, but it's the trial and error process. And a lot of people love them. You'll hear about people being on them for 5 years, 10 years sometimes.
Yeah, they come in for their 1 a year, oil change. They kind of joke about it. They go back out. You see them in a year, and they do great. They really do.
Yep. And I guess from there is then where Dr. Johnson is going to be consulted for surgical interventions. I guess is the next level up. Right?
I think that's key, and that's where we sort of move into that discussion. So everything up to that point is really, again, targeted at that inflammation, that the arthritis causes, and this is the first time we can, quote unquote, cure the arthritis. And maybe that's not, I guess it's overstating it a little bit. We're getting rid of the arthritis, and that's, I guess, in some ways a cure. Almost resurfacing the joint. So we're going to get rid of the arthritic surfaces of in the case of the knee, the end of the femur, top of the tibia, and we're going to replace those with metal, nice smooth surfaces that kind of take away that sort of irritation, both the mechanical irritation from the irregular joint surfaces, the responsive inflammation of the surrounding tissues, synovial tissues that line the joint, and we're going to give you basically a mechanical replacement for that knee. And so for many people who have gone through that course of care, it's an appropriate line of treatment. So we end up taking away a small portion of the bone to replace with metal. And that's something that we're kind of showing here.
Yeah, so for those who are watching on video, this is an example of a natural knee here. And we have the kneecap in front, and you have all these tendons that put that together. And in between, you have healthy bone and lots of cushion in between. And for those who are watching on the video, here's an example of a knee replacement. And like Dr. Johnson said, how would you describe what you're doing to the bone?
Yeah, right so basically we're planing it down.
Cutting, it sounds kind of gruesome.
It does. I talk about sort of planing it down. We're trying to get nice smooth surfaces to attach the metal to. That's usually put in place in the case of the knee replacement with what's essentially like a bone cement to kind of hold it in place. But this is all kind of what we're doing in the operating room, making sure everything is appropriately aligned, retensioned. We're trying to basically take a knee that maybe has collapsed, has some deformity, definitely has wear and tear, and bringing it back to look more and more like a normal knee in terms of its overall alignment and position.
So, now, watching that knee, as Dr. Joe, you're moving it, that steel that is put into the knee, not everybody's knee is the same size. So
Good question.
Absolutely right. So there's absolutely right. We do a lot of times ahead of time is get some advanced imaging, or at the very minimum, some regular x-rays. And we're going to do a lot of templating. We're going to try to get as close as we can to accurate measurements off of those images to make sure we know what's going on. And then intraoperatively, we're going to fine tune those measurements to your knee in this case, or the hip if it's obviously the hip joint. And we really want that knee to be as close to perfect for you as we can make it. And so there's all kinds of sort of half sizes and full sizes. It's a very glorified version of going into the shoe store. And so you're going to find something that fits your foot pretty well. It doesn't have to be a custom made shoe necessarily to fit you well. And so in this case, we're going to find those right measurements and make sure before you leave the operating room that everything is optimal, full range of motion, good stability. We want that knee to work well for you. And we're not going to let you leave the operating room until we've gotten to that point. And there's a lot of checks along the way in the course of the surgery. We'll put in sort of templates and make sure everything fits well. And then before we put in the final implants, once those go in, we want them to be in there optimally forever. We don't want them coming out at any point. So they're well affixed, well cemented, and we don't really put those in until we're confident we've got the right size for you.
Now, is the patient out? Is the patient out when you are?
Absolutely.
Oh, yeah,
Absolutely.
it's a question I get asked too. You know, is there
100%.
any hypnosis or any nerve blocks where someone's awake but doesn't have to get full anesthesia? I get that question all the time,
Yeah, so,
and I say no.
Yeah,
but...
my point of view is I don't come to your workplace to talk to you. I don't want you talking to me while I'm working. So I want you asleep, comfortable, out completely.
You don't want to be awake for that.
You don't.
Yeah.
And so, yes, we do still do things like nerve blocks, because even though you're asleep, those nerves could receive, stimulation from the surgery. So by blocking those nerves, we're actually going to be able to use less sedation than we would normally need to do. Now, that may sound a little scary, but you're going to be asleep, and we're going to be monitoring you the whole time. It just means you're a little bit less deep asleep, and that's a less risky type of anesthesia. So all those things are very positive. And of course, after you wake up, those nerves will still be asleep. You don't want to immediately know all about what I was doing in the operating room. So that gives us a good, usually a day or so to let that gradually wear off and then cycle in more of the pain control methods that we would use, the pills, the IV medications, et cetera, to maintain that level of comfort as we go further and further out from the surgery.
So I just wanted to back up to one point here. The customized replacement. A lot of people have questions like, okay, can I, whatever, what's the actual company name that does that again?
Conformis.
The Conformis knee, where you get a CAT scan ahead of time. Now, the last time I talked with Dr. Sellers on this, I think it was a few years ago, and similar to your shoe size or your shoe analogy, you get it custom fitted to your shoe and, well, sometimes it doesn't fit. Is this true for the Conformis knee too? Sometimes despite all the CAT scans and the manufacturing sometimes, and I think I heard 30% of the time, approximately, when it's shipped in, that custom one that's custom built for you, it doesn't fit and you got to pull an audible with the standard one. Is that true?
It can happen. Yeah, I wish I could tell you it's been 30% in my experience. It hasn't been quite that high, but there are occasions, and I don't mean to question the studies, but I would say, certainly it's depending. But it is a concern. And so something to be aware of when you're doing that procedure, that yes, that's the idea. It's going to fit you perfectly. And a lot of essentially their jigs that we use, the devices that we use to help prepare the bone for your implant, are going to be custom made to you, but they do have some variance. And as much as they can give a millimeter or two in any direction, we want to make sure that we're getting that custom implant directly where it needs to be. And so there's a little bit of variance that creeps in there. So we want to make sure, again, with any of these, that it fits you well and works well. And so if that custom made implant isn't quite right, absolutely correct. We go back to the standard sizing and can up or downsize depending on what the need is for your particular knee. So everything is very much directed to the patient. And as much as we have that plan ready to go, we've got backup plans for our backup plans just to make sure.
Yep. And so the knee replacements, sometimes done in the hospital, sometimes done in the outpatient setting, depending on multiple factors, of course, insurance and the patient's medical comorbidities. So the actual surgery itself, the big hot topic these days tends to be the muscle sparing approach. So the person's in the operating room asleep and your incision, it's kind of to the side. It's not that straight up and down one, it's to the side and you're not cutting muscle. So And that's kind of the newest, latest and greatest, that and the Makoplasty, the navigation guided, right?
Absolutely,
That's kind of
yeah.
the next steps.
And that's it. So with those muscle sparing techniques, the whole idea is you're trying to minimize the collateral damage you're doing during the surgery. Surgery, under the best of circumstances, is a controlled trauma, and the body is going to react to it in that way. Now, we're doing it in a way to try to minimize the damage that we have to do to get in and fix the knee, and this is a great way to kind of minimize that damage to the muscles. One of the big ones that comes in and attaches to that kneecap has traditionally been removed, detached temporarily during the surgery. Well, it needs to grow back onto the bone for it to function well. And that's a process. And if we avoid that damage and that muscle remains attached, it can start functioning for you the moment that you wake up and that nerve block is worn off, you're ready to go. It's not to say that there isn't, additional, we got to obviously make an incision and those things take time to heal. But if we're doing less damage overall, there have been studies that show less pain and improved function during those first couple months after the surgery versus that more traditional approach where we detach the muscle and have to reattach it later. So it's a very nice way to kind of improve the head start that people have coming out of a fairly big surgery already, a little less damage, a little less pain, a little better function.
And the other new thing you guys are doing is the Makoplasty, which is that navigation system. And if I understand right, you're kind of putting a little navigation pole in part of the thigh bone and part of the calf bone, and then kind of telling the computer where the surfaces of the joint are at, so that way it can make some measurements, and it's kind of double checking you and your exact cuts.
Yeah,
is that how you think about it?
It's a great way to put it. So those little devices allow the robot essentially to see where your bones are in space, in the room itself. And it knows where things like the instruments that we're going to use to make those cuts on the bone are, and it can bring those two things together within less than a millimeter of difference. And that's great. That allows us to implement that plan that we were talking about just about as perfectly as is possible. And so to do that, yes, there's a little bit of advanced planning. So we have to get a special scan so that the computer has a good 3D model of your knee. And it's a little bit different about how we go about making that plan. So the computer allows us to visualize the implants on your knee or in your knee before we make any cuts. And it allows us to simulate what motion will be and how straight it's going to be and all of those factors that we, kind of see in real time during the course of the surgery, but we can do that before we've even made our first cut of bone. And that's hugely powerful as the surgeon to be able to make sure and double check and visualize all of those things. So it's a great suite of tools for us to make sure that we're getting that best possible knee for you and getting it done efficiently, quickly, and as perfectly as could be.
So where
Dr.
Joe, where is the that image, that computer image, where is that taken? Is that at your facilities then?
You're doing CAT scans or MRIs?
So they are doing CAT scans. So yeah, there's a number of places in the area that we can do that we have partnered with that collect those images on our behalf to the specifications that we need to do that surgery. And then that all gets funneled into the computer kind of behind the scenes, nothing that the patient himself or herself needs to worry about. So,
yep. Now, maybe just a quick little tangent here, but sometimes a person is bone on bone in the inside part of the knee, and we're wondering, are they a best candidate for a partial knee replacement or a full knee replacement? Now, with those people, oftentimes we're getting an MRI scan before deciding what the best surgery is. Is this a surgery that Dr. Johnson just has to go in and kind of clean out the knee, smooth out some surfaces, or is this a person who just has bone on bone in one part of the knee and maybe they're a candidate for a partial knee replacement, or is there things on the x-ray that we're missing and a partial knee replacement wouldn't be as helpful for them?
I think that that's so key. And when we're looking at that decision, it's obviously a significant one. You don't want to find out in the middle of a surgery that, whoops, we're doing the wrong surgery. We should have done this bigger one instead, or we could have gotten away with that smaller surgery. And so all that pre-planning, the MRI is hugely helpful. And so that is one that we can do at our facility and gives us a great deal of information about the soft tissues within the knee that the x-rays can sometimes hint at, but it's indirect evaluation. We can kind of see spaces where the soft tissues are or maybe aren't, but looking at the quality or looking for irregularities that are lost in the x-rays, that's where the MRI is hugely helpful, and make sure that we're getting the best surgery or the minimal invasive treatment for you that we possibly can to get you the best knee at the outset or at the end of things.
So I guess a couple other questions about the surgery here. So you're putting in the cap on the top and bottom there, and in between, that's a kind of just plastic that's easily popped in and out. I mean, because I know you guys talk about replacing those very easy, the plastic. What is?
Yeah, it's pretty neat stuff. So basically, there's the piece of metal here on the top of the tibia has a recess, and that plastic will kind of click in there. And once it's in, it is very, very stable. And so that kind of holds it very nicely. On the other hand, if parts of the knee are likely to wear out, that is the piece. And so if it does begin to wear down, we're able to remove that with relative ease during the course of the surgery. And then we can put a new one in there. It clicks in, it's in there for good. And hopefully that's, changing the tires, get you back on the road, and a short pit stop to get, life going again. And so it's a much simpler surgery, all things considered, than the full knee replacement where we're making those cuts in the bone and putting in the metal. By comparison, there is a little bit of downtime just to heal incisions and so forth, but nothing like the initial surgery where there's a prolonged course of recuperating from that bigger surgery. So it's a very nice way to kind of maintain that knee and increase its lifespan beyond the manufacturer's warranty, so to speak.
Okay, Dr. Johnson, what's the rehab time on that surgery then?
So really,
for the plastic replacement?
For the replacement part. So usually it's a couple of weeks of relative rest, allow the soft tissues to heal. We do some range of motion activities early after that, though. We don't want scar tissue tightening up the knee. And then some people will benefit from a few weeks of additional therapy after that first couple to kind of just get the strength and the motion back up to speed. But a lot of folks don't need a whole lot more than that. I usually kind of err on the side of caution, tell people to expect a 4 to 6 week window to kind of downtime and ramp up and being back to pretty normal function around that time. Everyone's a little bit different, of course. It can be a bit less or a bit more, but roughly in that time frame.
You'd say a much quicker return to golf or whatever else than the first time they went through the total knee replacement.
That's it. And I think a lot of people
replacing just the plastic.
That's it. And when you've got that memory of going through the total knee, which again, big surgery, long recovery, a lot of work to get back up to speed, but again, gets you up to good level of function. I think by comparison, when folks go for that replacement, they're usually pretty pleasantly surprised about how much less intense the recovery is.
Yeah. And what kind of metal are you guys using these days?
So usually it's a cobalt chromium. The best, kind of shorthand for that is like a surgical stainless steel. And so it's a wear-resistant metal, very solid, very resistant to cracking or breaking, and allows for most people a great surface. If there are people who have certain allergies to metals in particular, which are thankfully pretty rare, but nickel being the one. So if you've ever gotten a funky rash from that cheap piece of jewelry, it's best to know for certain. We do send you for allergy testing, in which case we can use a titanium implant, which is, again, available, but something we need to plan ahead of time, know that coming in.
And these are MRI compatible. So if you need an MRI on your brain or on your rotator cuff or something, this would not affect the MRI.
Yeah, exactly. That's a great question too. A lot of folks have that one. And the other one is am I going to beep when I go to the airport? And yes, you very well may beep when you go to the airport. On the other hand, to the best of my knowledge, nobody's been asked to show the implant. They just kind of wand the knee and they know you're okay and they move you onto the plane.
So the surgeries are TSA compatible.
That's right. Yeah. Thank goodness. Yes.
They're very used to these things these days. Yeah. What about the ligaments? So you keep the natural ligaments there. Do you ever have to reconstruct those? How does that process work with your ACL? I had an ACL tear before, Doc. I had an MCL tear. How does that work with a total knee replacement?
That's it. So for knee replacement, traditionally the ACL is actually going to be removed. We don't need the ACL after this surgery. The implants themselves will be stable in the way that the ACL used to help increase the stability of the knee. There are two schools of thought about the PCL, which is another ligament behind it. Generally, we keep it intact, but there are some implants that actually can remove the PCL. So if you've had either a bad PCL injury and no longer have one, or it's compromised, it's very easy to do that implant. In fact, if it's something that we find out intraoperatively, maybe you didn't know you had a bad PCL, we can always change over in the course of the surgery. There's minimal change in terms of the implant, and it's something that the patient themselves would not be able to notice the difference. The other ligaments that you mentioned are the MCL and the LCL, the inside and outside parts of the knee. We actually maintain those. And so the idea is to use the natural length and tensioning of those ligaments to help to stabilize the knee. We want a good, stable knee for you. And so we'll actually make our cut adjustments or sometimes do a little bit of soft tissue work to make that knee stable, meaning that those ligaments are taut at the right tension to allow normal full motion of the knee, but good stability throughout that entire range of motion. We don't want that knee wobbling on you side to side. And so we'll actually assess all of that intraoperatively. And so there are occasions where we'll need to do a little bit of lengthening of those is the more common thing. But it's not terribly common that we have to do that. A lot of what we're trying to do with the implants is to meet the ligaments where they are, as opposed to try to get the ligaments to meet where our implant is.
Yeah. Now the PCL is something that I've never heard of before.
It's a very rare injury. It's commonly a dashboard injury. So people who have been in motor vehicle accidents, they'll hit the front part of their knee and it'll get driven backwards. And so that's what the PCL does, is that posterior restraint. So if that tibia the shin bone wants to push backwards, that ligament's there to catch it. And so those are the kinds of things that we'll sometimes see. It's not a very, very common injury. You really got to work at it to get a PCL injury. So thankfully, most people have one that's intact and it's not so much an issue. But that ACL, that poor ACL, though, seems to catch all the brunt. That's that common sports injury and plant and twist motion. That's it. So.
So the whole procedure, knee replacement, about an hour, the patient's under, the actual surgical work?
Something like an hour and a half, depending on the patient. There's always a little bit of getting them sleep comfortable time and waking them up comfortable time. And so those are things that can kind of vary the overall time in the operating room. But the actual surgical time is relatively brief. In that range, I think is fair. Yeah, 60 minutes or so. And
so we said some people, they're healthy enough, they're young enough, they're going right home with home nursing, physical therapists coming by and whatnot. But the people who are in the hospital, typically they're there for a night or two, just doing some rehab, having some assistance with, getting to the bathroom, getting their meals, stuff like that. So typically it's a few nights.
A few nights
in the hospital.
That's what I usually tell folks to expect. I've had a couple of folks who are really excited. They spend their one night, they get their antibiotics, they're finished up, they are ready to go. In which case, go on home as long as everything's medically safe and sound. I think more people probably the 2-night window is probably about right. And there's some folks a little slower to get up and go. Maybe they've got some other medical concerns that are slowing them down or what have you. And that's okay. You're not interested in kicking you out the door. I want you to get you home safely. I don't want you doing a big U-turn in your driveway coming right back because there was a problem. But I think for most people, that two-night window is probably pretty typical.
And some people worry that they're going to be in the hospital longer or that they're going to have to go to a skilled nursing facility, a rehab facility. Are there certain factors that maybe lead to a person not doing well? I mean, history of just anesthesia issues or, diabetes or, obesity or, deconditioning. Are there certain things that make it more likely that you're not going to head straight home afterwards?
I think that deconditioning is probably a big one. And that kind of goes back a little bit to that beginning of that ladder we were talking about, the physical therapy stuff and people who have kind of had those gradual changes occurring because of the arthritis that they don't even know about. And that's a lot of times the muscles getting stiff or weak. And so the knee itself, let's say, is maybe not up to full speed. Well, you've just had a big surgery. Everyone's going to take a little bit of a step back at that point. If you're already a little further down on that mountain, all of a sudden it's a much steeper hill to climb. And so for those folks, they can sometimes benefit from a short stay in rehab. For the most part, though, we're assessing that at the time of your surgery. So you're finish up your surgery, and we spend the next couple of days working with you twice a day for physical therapy. They're going to be making these checks and sort of seeing how your progress is. And so everything is very much tailored, again, to the patient. Nothing is set in stone. I would say certainly if you're doing well and advancing, sometimes day one you look like you might need that rehab, but by day two, the swelling's down, pain is better, you're starting to move more freely. Maybe now you're going home with some home health care, physical therapy, home nursing, that sort of thing.
So when are they actually up after the surgery? When do you get them up?
Get them up that afternoon a lot of times. The one thing that would keep us from doing that is if people are still a little bit groggy from the anesthesia. But if they're awake and feeling well, we want to get you up and moving right away. And it's mechanically stable enough to do that. Now the block, though, will make those muscles around the knee a bit weaker. So we do sometimes use a brace to kind of give you that support and stability while you're getting up. But I think, number one, it's a huge hurdle for people to clear. I just had this big surgery. What do you mean I'm going to get up? Like, come on, let's go. Let's get you out of the bed. And that first step is really powerful for them to know that they can start building that confidence in their brand new knee. And then, of course, day two, as those nerve blocks have worn off, the muscles are coming around. Now they're doing more of that work. And so it's not that people are running marathons day one or day two, but getting up and moving, starting to do some laps around the nurse's station. All of those things happen very early on. And I think that's a big confidence builder as people kind of try to anticipate what their new life is going to be like for those first several weeks to get a good feel, get good confidence. And then I think a lot of times people are feeling better about going home and managing those conditions in the comfort of their own familiar environment.
So what's that that next day like, for the knee replacement versus the hip replacement?
Yeah, that's a tough one. Yeah.
Everyone loves hearing about the hip
tough,
replacement and just how dramatic it is that very next day. I mean, those are one of the most rewarding ones you
100%.
Yeah,
absolutely. The hip replacements are great. So people are up and moving without the benefit of a nerve block day one, and they feel great. You know, my mentor used to tell this sort of, you know, good story about how to kind of frame that. And so people, you know, he'd go by and see his patients the next day and they'd say, how's your new hip feeling? He'd say, oh, my new hip feels great, doctor. Thank you so much. He'd go by and see the knee patient and he would say, how's your new knee feeling? He says, your dang knee is still killing me. And so like it takes a while. And so finally around that 4 to 6 month window, it becomes their knee again. And so it's definitely a process. You know, I don't mean them to gloss over that. On the other hand, I think people are seeing that sort of day-to-day, week-to-week progress, and they're building the sense that this is going to be a good knee for me. I'm going to get back doing those things that have been so far out of reach for so long that, you know, I never thought I'd be able to do that again. And that's a great feeling when you start seeing those people realize that. So I think that that's kind of the key, is building that early confidence so they know that it's not going to be like that forever. But that said, yeah, the first few days, it's going to feel like, you know, you had a knee replacement. It's going to hurt, it's going to swell, but we're going to keep that pain controlled. We're going to build your function, your motion with the help of therapy, keep you comfortable with the help of those medications. All of that works towards getting you well.
So your average patient, you know, let's say in their mid 60s, maybe a little bit of cholesterol issues, a little bit of blood pressure issues, you know, a few pounds overweight. How quick are they returning to ballpark? And I know everyone's different.
Yeah.
You know, ballpark, what, 6 weeks?
6 weeks is what I sort of, if they're doing well, I'm usually seeing them around that time anyway to kind of double check. I would start sort of the light, you know, the putting, chipping type stuff, you know, light activity. I save the, you know, swing from the heel, Tiger Woods swings. It's probably like the 4 to 6 month window for many folks, not everybody. And I would say certainly in that 3 month window, you're building towards that. Maybe not up to full speed just yet, but, you know, maybe taking the cart, you know, maybe going a little slower, maybe only playing 9 instead of 18. But I think people are starting to see that game is coming into focus now. And whether they're good at it or not, I can't take any credit for that. But,
So then how about going forward? You know, are there any, you know, parting words, you know, that you're saying at the, you know, 6 month follow-up or 1 year follow-up, you know, are you telling them, you know, avoid ladders or antibiotic instructions? What are your final thoughts I think about as I let you free?
Sure. Yeah. There's a couple of key things for me. Number one is that from my standpoint, kneeling directly on the front part of the knee is something that I would like them to try to avoid forever. And the reason we do that, we did mention this specifically, but we're basically, the back of that kneecap rubs up against the end of your femur here. And we've just replaced that with metal. So if the back of your kneecap is rubbing up against the metal, you can imagine that's not going to be a particularly pleasant sensation. So we resurface, we put a plastic button similar to the plastic we're using in between the two parts of the knee. And that little button goes on the back of the kneecap. And so when that's on the back of the kneecap, that's what's rubbing against the metal, but we've had to thin out that kneecap a little bit and it can act like a fulcrum. It can crack around that button. So kneeling directly on the front part of the knee is a risk I ask them not to take because that's a very big endeavor to try to get that to heal. The other thing you mentioned, the antibiotics, is a little controversial, to be fair. On the other hand, as someone who takes care of the knees, I would tell you that I very much recommend lifelong prophylactic antibiotics. Antibiotics that you take before, let's say, a dental procedure, something that might shower the bloodstream with bacteria. In theory, those bacteria could find their way through the bloodstream and land on that metal or plastic. And since the body cannot get its normal immune cells, the cells that fight off those infections, to the metal or plastic, there's no blood supply to them, of course. That's safe harbor for those bacteria, and that can be disastrous. So for the cost, the expense, the headache of taking a single dose of antibiotics an hour before that procedure to minimize the nightmare that can be a bad knee infection after a knee replacement, I think there's no question. I would rather have them do that lifelong. But recommendations do very much vary in that. So people may read or hear about different recommendations, and it is, at the end of the day, the patient's call, but that's my recommendation to them.
So what's your feeling on something that's non-dental? Maybe they're getting a cortisone shot in their shoulder, or maybe they had a hip replacement and you're putting a hip bursa shot in that hip, or maybe a skin procedure. Are there any other?
Yeah, the
how do you look at those other ones?
Yeah, those are the ones that give me a little bit of pause too, because I think with the again, the, you know, like the like a biopsy of a mole, let's say, something like that, I do tend to recommend it. Okay. I think with the steroid injections, that risk is relatively low. Now that said, not that you were suggesting this, we obviously don't put steroids in a replacement of the knee. That's verboten. But on the other hand, if it's in some other joint, I think that those things are probably pretty safe. We don't see a lot of increased risk there. And even though there is a little bit of immunosuppression from the steroids, they reduce the ability of the body to fight off infection for a brief period of time. It's a fairly mild and a fairly localized effect. And that's why we don't put it in the joint that was replaced, but I think elsewhere is probably okay. Again, it is a matter of counseling the patient, though, that risk is there. And as long as they're aware of that risk, however low it might be, it's never, ever zero. I think it's probably a reasonable risk to take for most people for the benefit that they can get, especially if you've done all the normal stuff that we were, kind of chatting about earlier.
And so actually, it's been a while since I asked one of my surgical partners here. So if you did a hip replacement on someone and, 3 years, 5 years later, you needed to do a hip bursa shot in that same hip, you're okay with them not taking antibiotics for that? Or I'm not sure your guys' preference.
Yeah, that one, it's a little tougher. I would say you're in the vicinity. Now you're technically outside the hip joint, but you're pretty close to it. That one I might recommend it as a matter of caution.
I've been doing.
Yeah, I think that's probably just again, prudence, maybe abundance of caution, but I'd much rather err on the side of caution than not. But yeah, I think that might be a one exception to that general rule.
Okay. All right. So no kneeling. Be careful with beating up on it.
That's
don't
true.
go jumping out of planes. And we talked about the infection stuff.
And that's a good point too. I think people say, well, what are those activities that I can
go back to running?
do?
If they feel great, can I go back to cycling? Can I go back to running?
Right. And I think it's all a matter of relative risk again. Coming down to, okay, what are the odds that something goes wrong versus how much pleasure, how much enjoyment, how much satisfaction do you get from that activity? So listen,
you know how runners are.
Oh, that's what I mean. Absolutely. And so if your life revolves around running, technically, yes, you can go out and run on a total knee.
Assuming it feels okay.
Assuming it feels okay. Yeah, absolutely. Good
Some
point.
people it doesn't. Yeah,
that's absolutely right. Listen to the knee. If it tells you otherwise, it's the boss.
So I had to wait nearly 60 years to get out of kneeling at Catholic school.
That's right. All you had to do was get a knee replacement, Greg. You get a free pass.
I can get you a note. I think I'm on good terms with the man upstairs. I think. I don't want to assume, though. That's something I don't want to be wrong about.
All right. So, so return to activity really, is it going to wear it out that much quicker? I guess.
Well, and that's a great question.
If I go back to running, 20, 30 miles a week, is it going to wear it out sooner?
That much quicker? Probably there is that risk. Now, the average lifespan we're seeing these days is probably 20 to 25 years. That's under sort of normal use, normal conditions.
A total knee replacement, how long it's going to last for.
Exactly.
Could have problems.
Exactly. And to be fair, there's some that do go beyond that without any issue whatsoever. And so now it comes down to, okay, that is that risk. We talked a little bit about how to replace, different parts and so forth. And also there is I think the potential of getting back to those activities a little too early before all the healing is done. You worry about things either not being quite sturdy enough, so maybe the knee wants to buckle or give out from a soft tissue or muscle standpoint, or that you don't want to sort of interrupt the healing of that sort of the bone and metal interface. You want that to be healed really well. So I think with that in mind, if you're at that good point, it doesn't hurt. Yeah, there's probably a slight increase in risk in terms of how quickly it wears out under normal circumstances, but let's say you're a recreational runner or someone who runs for health purposes and does so on a fairly routine basis is going to be a little bit different than someone who's out there running ultra marathons and flip-flops on frozen cement. There's degrees of impact. And so everything's got a little bit of risk to it, but I think if you know that risk and can kind of weigh it against the benefit it gives you, I think that those are reasonable decisions. Again, harkening back to another mentor who used to actually work as the orthopedist at a ski resort up in the Northeast. And so he had a little shop at the bottom of the mountain. So when you came tumbling down in 1,000 pieces, he'd be there to patch you back together. So he knew a lot of patients who would go on to have knee replacements, and they would be like, well, can I go back skiing? He's like, yeah, that's why we did the knee replacement, is get you back doing those things. Yes, you could trip and fall and break, and you could wear it out and all those things. But if you enjoy skiing, go enjoy skiing. So I think it's all about that.
So obviously we got to talk to people about the risks, and hey, you better take care of your good surgical work. Otherwise, because if you have to come back, it's not so simple. So I guess if I remember right, average lifetime risk of getting that knee infected, 1%, maybe a little bit more?
Somewhere in that vicinity. Now
you could have an infection in that knee.
Exactly right. That's probably the biggest fear at the end of the day.
And then you said about the lifespan of the knee, 20 to 30 years-ish. And so do you have to scare some people and say, you better take good care of this because this is what's involved? So what is that?
Yeah, my sense is you read them the whole horrible list of doom and gloom and let them know, listen, these are all the things that can happen, and this is why we want you to maintain the do's and don'ts. At the end of the day, all of those are low but non-zero risks. We're doing everything humanly possible to steer clear of them, but even under the best of circumstances, they can still happen. And sometimes people do take a step back and they say, well, maybe money's not that bad. I can live with it. And that's good. They should make that decision based on those factors. But there is sometimes that reminder, like, hey, remember we talked about this before the surgery. You got to avoid that. You can't be doing this thing. And those are good reminders to have just to keep those risks fresh in people's minds.
Yep. And so if someone does need a revision surgery, let's just say that the metal gets loose. that's not so simple for you to go in there and take everything out and put bigger stuff in and reinforce it. It's
yeah, those are daunting surgeries, and I would say all those risks that we talk about before the first surgery are increasing every time we go back in, and the bigger the replacement or revision surgery needs to be, the higher those risks are. And so that's where we worry about that snowball effect. And so the first time you get a revision, maybe it goes well, but no, maybe it doesn't. So maybe you're looking at a second revision, or something else can happen down the road. So all of those things are risks to be aware of. And that's why we want to give that knee the best shot we can.
Well, you talk about revision surgery. Knee surgeries have changed dramatically just in the last 20 years. So
absolutely, yeah,
that could be pretty dramatic for the patient.
It really can be, yeah. And so it's neat to see where these technologies have kind of led us, and some of these newer techniques, and some of that technology involves some of the replacement implants and how we're going about fixing those problems that happen. Obviously, the equipment that we're using as well in the operating room is very different. And I think there's probably going to be a role as we get more and more kind of expansive with some of these robot techniques as well, to kind of use them to our advantage during some of these bigger surgeries. So I'm certainly very hopeful for the future. But obviously, if we can steer people clear of the pitfalls before they get to them, that's much easier than trying to pull them out of that pit once they've fallen into it. But we're here either way. It doesn't doesn't mean you can't go and try some things. It just means we've got to be cautious.
Any other high yield pieces of info? I mean, we talked about the whole arthritis spectrum here, and trying to do things that are low risk, high reward, all the way up to the surgery that has a little bit more risk for the reward. Any other parting things that you think are especially important here?
I think just in general, I would say don't compare your knee or your hip to anyone else's. Yeah, you are a unique person, and your arthritis, your medical issues, your surgery, your recovery, they are going to be different, 100%. Your left knee from your right knee, going to be different. So deal with you and your knee, and we're going to help you through that process. It's you in a very specific way, not a knee more generally. We're looking at the whole person when we do these things.
Yep.
So you're not like the guy next door then, right?
That's right. Exactly right. And sometimes that's good, sometimes not as much,
Well, yeah, good. And so, of course, any questions, call us on Bone Talk next week. Greg, what's the number for normal Bone Talk? 772
340-1590 is the studio number.
340-1590, 772-340-1590. If you want to call us next week on Bone Talk, or of course, if you want to come in and see me or Dr. Paul Johnson at Florida Orthopedic Specialists, our telephone number at the clinic is 772-335-4770. And that'll connect you to the main line to come and see us either in Stuart or in Port St. Lucie. Again, in Port St. Lucie, we're off of Highway 1 and Walton Road, and in Stuart off of Highway 1 and Indian Street, more or less. We're here 5 days a week. We'll be 6 days a week again soon, once the virus thing settles down.
Recent unpleasantness, yes.
And I think that's it. And of course, check out the website. We'll be doing a lot more videos. We'll be doing Skype videos, Zoom videos, and of course, always on Bone Talk on WPSL.
All right. Thank you very much, guys. Talk with you soon.
Thanks, Dr. Johnson.
WPSL.
Thank you. Take care, everybody.